Well, good morning. I was a little concerned on my way over that you might think I was going to talk about how to stay forever young. But I don't know how to do that. I'm a participant observer in the aging process myself, and perhaps you might have some better ideas about that than I do. Mainly I'm going to be talking about what I'm going to call the bad curve, and has to do with sort of the interface of demography and public policy. Gavel, power. And I'm using equipment I'm unfamiliar with, so I'm just hoping it'll all work, but it's magic. This thing's going to advance slides from over here whenever I push it. I want to start with a story about the bad curve. Back in 1935, when President Roosevelt's Committee on Economic Security was finishing up the last bit of the Social Security legislation, two of the committee members had come together to discuss the projections that had been made for Social Security expenditures under the proposed program up through 1980, which seems like history to me today. Harry Hopkins, the head of the Federal Emergency Relief Administration, turned to a fellow named Henry Morgenthau, who was the Secretary of the Treasury at the time, and he said, this is a true story, "Well, Henry, there are going to be about twice as many old people 30 years from now." Morgenthau apparently replied something to the effect that, "Oh, I've gotten a very good analysis of this thing, and it's not just a matter of more old people. I want to show the other members of the committee the bad curves." Hopkins said in return, "Yes, that old age thing is a bad curve." I think for most of us, on a personal level, facing old age, it's a bad curve sometimes. But what they were referring to was the projected ratio of workers to retiree beneficiaries. And they knew back in 1935 that there would be some years of very favorable ratios where the number of workers contributing into the system would far exceed the number of recipients. But they could, even back in 1935, foresee down the road when the smaller birth cohorts that were being born right then in the 1930s were going to be supporting the much larger cohorts that had been born before them, along with the flood of immigrants that had come into this country as young adults in the latter part of the 1800s and early part of the 20th century. So they knew there was a bad curve a-coming. Now, the nutshell of what I want to convey to you today is the bad curve that they saw in 1935 turned out to be much worse than they ever anticipated. Life expectancy went up far more than Henry ever thought it would. Nobody in 1935 foresaw the coming of the post-World War II baby boom, and absolutely nobody foresaw that Congress in the heady days of the 1960s and 70s would greatly expand the benefits under Social Security. So all of these changes that did occur that they didn't see certainly resulted in worsening, exacerbating the bad curve that they did see. It put the Social Security Administration into a real bind by the 1980s, and major changes in the nature of the policy were put into effect then that it has kept it afloat more or less since then. So my talk today is about a bad curve, but it's the bad curve for the 21st century. And I think it's a worse curve than they were facing in 1935. And the primary problem is really not just the economic support of the retiree population, but also the health care support that has been added in since then. So, by the way, underlying my title slide there is the bad curve, but I'll come back to that at the end. So let me see if I can now figure out how to advance this thing with my little magical thing. Oh, I'm not. Hold that. Okay, let me start by just defining my term. We all know what personal aging is. We see that when we look in the mirror. But population aging is a little bit different, a very macro concept. Population aging, it happens when you get an increase in the proportion of older population relative to the younger population. And contrary to what most people think, population aging is really driven by declines in fertility. Because you can have rising life expectancy as they have had in say, a place like Saudi Arabia. And if you don't have declining fertility, you will stay, population-wise, forever young. So you need to have that decline in fertility so that the proportion, that smaller cohorts will come in at the bottom of your age structure, and the proportion of the population in the older ages increases. And on this chart, I put a little fertility chart at the bottom there, and if you look at the top, I see my colors aren't coming through too well, but if you look at the top line where it says number, that's the raw number of births in the United States from 1930 to 2000, and you can certainly see that U.S. fertility has been a definite roller coaster throughout the 20th century. I'm sure we've all lived through it. We know that. If you look in terms of raw births, fertility in the 1940s, American women were putting out 2.6 million births. By 1957, that had increased to 4.3 million births. That's, of course, the big baby boom. It hovered around 4 million births to the mid-60s, and then it declines as we went into the birth-dearth period of the 70s. In fact, it went down almost to 3 million by the mid-70s, and then you can certainly see the echo there, can't you? As it starts to rise again. And now, I always feel the need to tell I'm a teacher. Now see the raw number, compare that to the rate. There's two different stories there, isn't there? The rate stays down, but the raw number goes up. And that's an important part to realize. It's not that women are necessarily having a whole lot more babies, is it? It's really that there are a whole lot more people in the country to have babies. So when it comes to something like health care, it's the raw number we really do care about. Because it's the people that are going to need the services. And knowing that I was going to speak to the Humanist Society today, I thought I should put a human face on the baby boomer. And I had a lot of fun finding these pictures on the web, and I probably violated all kinds of copyright here. But look at this wonderful little 1950s family, could have been yours. And then you can see, don't you like the bouffants, hairdos, remember those? The early 60s. And I sure remember the next one, you know, the Woodstock generation. And I certainly remember, and I'm sure do many of you, the anti-war protests. And then eventually the boomers settle down, get married. Is that not a sweet wedding outside? And have their family. Now, big difference between the family with 4 children that they came from and the family of 2 children that they had, right? And here we are, us boomers, right today. So these are the real people that I'm going to be talking about. And because I'm going to be showing you a lot of charts, I just wanted to make sure that you understand behind all the numbers, there are real people with real issues that need to be dealt with. Markers love charts. This is, we call these age structures. And let me just take 1 minute to explain what you're looking at here. You have here what is basically a bar chart, but it's turned on its side. So each bar represents a 5-year age group. The bottom of these age structures would be 0 to 5, right? And then the next category is, well, it's actually 0 to 4. The next category is 5 to 9, 0 to 4, 5 to 9, 10 to 14, etc. as you move on up. And we put females on one side, and we put males on the other side. And we sort of love these kinds of age structures because in one picture it tells you an awful lot about the population. And you can see that in 1900, the U.S. population was a very young population. 52% of the U.S. population was under the age of 25. And only, and I bracketed it off there so you could see, only 4% was 65 and older. So we were a very young population. And you can look ahead to 1920, and we're still a very young population. By 1940, do you see the little nipping in the youngest ages? That's, of course, because in the 1930s, fertility plunged, as we just saw on the previous chart. And but by the 1960s, what's happened to fertility? It has rebounded very strongly with the baby boom, and we are still a very young population. And then I ended this one at 1980. By 1980, the percent of population under 25 was still 42%. That was higher than any other developed country. Much higher than any European country, than Japan, than Australia, New Zealand. We were still a very young country. We had, by 1980, 11% of the population 65 and over. Today, it's just about 13%. So, we are rather different than other developed countries, and one of the things that has made us different is the fact that we have had such a large wave of immigration. Immigrants keep us young. Most immigrants who come into the United States come in as young adults. Now, they may bring their children along with them, but even if they don't bring children along with them, they bring their potential fertility in them and have their children once they're here. And since a large portion of the immigrants in the United States are coming from Latin American countries where fertility is higher, they have a secondary effect of increasing our overall fertility rate. So immigrants are keeping us younger. And I'm going to show you another country by comparison in a minute or a slide or two. I forget exactly where it is here. There we go. So immigration also, even though fertility is the driver and you have to have fertility decline to get aging of a population, immigration also affects the process. And if fertility was a roller coaster, I don't know what you would call immigration in the United States. The fluctuations are phenomenal. We had a huge wave of immigration around the turn of the 20th century, which you can see there. Immigration dried up in the 30s. Obviously, not too many people were immigrating during World War II. And then after World War II, you can see it beginning to increase. But the main thing that led to the last huge wave of immigration that we're still in the middle of was a change in immigration policy in 1960, called the Family Reunion Act. And that opened the door for the first time to immigrants coming from Latin America, Asia, and Africa. And so, in terms of raw numbers, we started to get about 600,000 immigrants a year in the 1970s. By the 1990s, we were averaging over 900,000 immigrants a year. Now, I'm only talking legal immigrants here. There's an not equal is the wrong term, but there's as you all are well aware living in Arizona, there's another flow of immigrants, the undocumented workers that are flooding into this country as well. Yes?
I'm sorry, but because I'm aging quite well, what is the peak around 19...
Oh, do you mean the IRCA legislation?
Yeah, what does that say?
This right here?
Yeah.
Okay, that is when we had amnesty. That's the amnesty reform that allowed undocumented residents of the United States who had evidence of a work history and I forget all the ins and outs of the policy, but could show that they had been here and paid for housing and so on to become legal residents of the country. So that is an enormous spike at that period of time. But that's under IRCA.
So if you took into account the illegal aliens, perhaps it'd be a huge spike on the end of the whole thing there.
There would be. How big that spike would be, I can't tell you, because of course the great unknown is how many, I don't know what terminology you want to use, illegal immigrants, undocumented workers, those are loaded terms that mean and imply very different things. But how many are living in the United States, we really don't know. I mean, we used to guess back in around 1980, we used to guess it was 4 million. By 1990, we thought it was 5-6 million. I think the official guess these days is 11 million, but it might be 15 million. A lot of people think we just don't know. But they're here. And they are drawn from the same pool of people as our legal immigrants in the sense of they are young adults who come with their children or bring their fertility with them. So they're keeping us younger too. So my main point about immigration is keeping the U.S. much younger than it would otherwise be. Now, while immigration is keeping us younger, changes in life expectancy are aging us. And this looks at the change in life expectancy over the 20th century. And I thought that the charts, you know how they say lies, damn lies, and statistics? And I wanted to narrow up that chart and make those columns much bigger to make it look more dramatic. But you'll have to trust me, this is a huge change. There was a 30-year gain in life expectancy over the 20th century. 30 years. That's considerable. If you look at 1900, male life expectancy was 46 years. Now that's life expectancy at birth. By 2000, it had risen to 74.4 years. That's just a huge increase. Way more than Hopkins could have ever imagined possible. Now, I can also tell a little aside, the big increase in life expectancy in the 20th century came in the life expectancy at birth, which is what I have up there. And the reason it came is because infant mortality decreased, childhood mortality decreased. As I always like to tell my students, back in the early 20th century, all the coffins were small. Parents buried their children. That's not the case today. Now, we have had gains in life expectancy at age 65, but those have been in the last 20 years. And those are substantial, but they're much more recent. Those would be what we can look to in the 21st century, I think. But the big gain, we probably won't have a 30-year increase in life expectancy in the 21st century, but let me tell you, demographers, well, we at least are honest. Economists love to do projections and they think they're right. Demographers love to do projections and we know we're wrong. We're always wrong. So maybe it will be another 30-year gain in life expectancy in the 21st century. But I can't provide the supporting evidence to make that argument at this point in time. But certainly the gains are going to be coming at the older ages as they have for the last 20 years. Looking ahead to the 21st century, here are the projected life expectancies for the United States. We'll just take males, for example. Oh, I should tell you, because we know we're always wrong, we like to hedge our bets. So we never do just one projection. We do the high series, the medium series, the low series. And what does everybody do? They always grab the medium series and call that the forecast. But I can tell you that's never right. So, I make it a point to try to avoid the medium series. And so what I've got up there is two sets of projections. If you can look at the labels at the bottom. I hope they're visible. Is that big enough at the back of the room that you can read them, I hope?
No.
Oh, well here, let me see my trigger here. This is the low estimate for 2100. This is the low estimate for 2050. This is the low estimate for 2100. So, let's talk males for a minute. Male life expectancy in 2000, 74.1 years. Under the low estimate, it puts males up to 85 years by 2100. Okay? Now, the other two bars are the high estimate. So, by comparison, males who today are around 74.1 years in life expectancy at birth. 2050 under the high estimate puts them just a shade under 85 years, and by 2100 they're a little over 88 years. Gives you some idea of the expected range. But I can tell you, having looked at the history of population projections, probably not right. May well be higher. Could well be lower. It's probably not right. I think we could say that we anticipate at least a 10-year gain over the 21st century. That I think is fair to say. But it could well be more than that. Because many demographers feel that the high estimate, this is official National Center for Health Statistics estimates, Many demographers feel that even the high estimate is too low, given the substantial decline that we have had in the death rates for cancer. Not so much for cancer. Cancer has come down a little bit, and that's only very recently, but that's good news. And if you look at individual kinds of cancer, some individual kinds of cancers have come down very substantially. But it's offset, unfortunately, by the continuing epidemic of cancer related to smoking, which has increased, particularly for women, what we're seeing in this generation, the increasing rates of lung cancer for women. But mortality from heart disease, mortality from strokes has plunged. It's just, oops, oh dear.
Just go back. Just go back.
Anybody know how I do that? Let me see. If I do that. Okay. Previous. Okay. There we go. Oh. Yeah.
You were there.
You were.
No, that's the one I want.
Oh, okay.
Where's my chart? There's my labels.
It says you need QuickTime.
Oh. This isn't my laptop. This is one I borrowed from the university.
Previous will be the back to the bottom.
But this is the one I want, and I guess it's not going to show. Looks like that. Oh, I'm bummed about this. The decline, well, you're going to have to take it on faith without any supporting evidence. Uh-oh. Not the right thing here. I don't like to take things on faith myself, which is why I like all my charts to show you the data. Heart disease, if anybody wants proof, come see me afterwards. And you can look at my chart. Or you can go to the CDC site and look it up yourself. Heart disease death rates have come way down in the United States. Even more impressive is the decline for strokes. It's really impressive. And it is having an impact on life expectancy of people 65 and over. And there's nothing magical about 65. I've just taken that as we all do as an arbitrary cutoff to talk about the older population. There's nothing that at 65 makes you much different than at 64. Obviously.
Medicare.
Oh, wow. Which is very significant and the main point I'm going to be getting to. Okay, but the bad news out there is that the death rate for diabetes has been climbing, and the death rate for chronic obstructive pulmonary disease, again, probably related to smoking, exposure to asbestos, and some other of the 20th century, what would you call it? The material culture of the 20th century is probably playing a role in that. But COPD and diabetes death rates are up. But still, they are in the top 5 killers, but they pale by comparison to the number of people that die from heart disease. So those improvements in heart disease and the improvements in stroke, those being the top killers, are, well, in fact, stroke is no longer the second most often killer as it was back in 1950. Cancer is now the second most common source of mortality. Stroke has become a distant third because of the improvement. So it's good news. But obviously, when the mortality rate comes down, that will age the population. And so, to sum up the trends about aging of the population that we're looking forward to throughout the rest of the 21st century would be that unless there is a real sudden desire on the part of American women to start having 4 and 5 babies again. Do you think that's going to happen? I don't know. It happened once before. The women in the 50s produced more babies than their mothers did. It has happened before. But I ask my students about their fertility intentions all the time, and I don't see it happening yet. It'll be a later generation if it does happen. So, but unless fertility rises, and I mean substantially, and another alternative, we could have a massive, deadly epidemic.
Yeah.
Could happen. We like to think that we're past the era of communicable disease deaths, but I think AIDS has taught us otherwise. And of course, there's the SARS and the bird flu lurking out there. But the thing about mortality is, to change the pattern of aging, that mortality would have to very strongly, disproportionately affect the elderly population. And generally, when you have an epidemic, it affects to varying extents all the population. So, but unless we had some sort of epidemic that targets the elderly population, along with women suddenly deciding they want a lot more births than they're having today, and oh, we need one more thing. I suppose we need a really even bigger increase in immigration. Now, how big do we want to go? We're already 200, let's see, I think we have 292, almost 93 million people in the United States, and we're taking in over 1 million immigrants when we count legal and illegal together a year. How big do you want to go? But unless we have that, we're aging. That I feel confident about, even though demographers are always wrong. I think too many things would have to change in too radical a way, in a very unlikely way, to keep us from aging. So I think the story of the 21st century will be aging in the United States without any question. And what will that look like? Well, it's going to look a bit like this. Here's some of these age structures again. And I have the age structure for 2000, 2050, the projected out to 2050, and projected out to 2100. I have little arrows there marking where the cohort 65 to 69 is. And these age structures are a little different than the ones I showed you because we have had such a growth in the older population. This particular age structure separates out people 90 to 94, 95 to 99, and then it's 100 plus here, I believe. But now, so look at the top of those age structures. And you can see the really big change in aging is coming now, between now and 2050. Right? That's when the big change will come. Why? Well, it all goes back to those people involved. That's because around just after 2010, the leading edge of the baby boom generation starts to celebrate their 65th birthday. And by 2030, the trailing edge of the baby boom generation reaches 65. And even then, fertility was coming down, but it was still fairly high, but it was coming down. So those subsequent cohorts, which are getting a little smaller, but are still pretty big, are going to all be over 65 by 2050. So the big bulk of that aging happens between now and 2050. And what will America look like? Well, I think it will look a little bit, I'm trying to put this human face, I love some of these pictures I found. It's going to look something like this. Okay. Did you get my transition from the young old to the assisted care population? I had some pictures of nursing home. My husband told me to take them. So I did. To sum up the trend, this goes from 1900 projected out to 2050. This looks at the percent of the whole U.S. population that is going to be over 65. It's just an aggregate way of looking at the situation. Excuse me. You can see that in 1900 we had less than 5% of the population over 65. We are looking ahead. By 2030 we will have 20% of the population over 65. That's one in 5. It's unprecedented. I grew up in the land of hula hoops, Davy Crockett, Barbie dolls. It was not 1 in 5 people over 65. It is a very different society that we're moving towards. And I said I was going to show you something from other countries, and on the next slide I'm going to, because as much as the U.S. is aging, it pales by comparison to what's going on in European countries, Japan, Australia, New Zealand. And so I picked a couple of countries up here, picked Japan and I'm sorry, these are particularly wild-colored age structures. These are right off the Census Bureau site. They have this neat software that allows you to grab a country and project it and stuff, which is neat. But they're a little bit colorful, more so than I like. But anyway, speaking of Japan, oh no, I did that. This is dangerous. Now what do I have to do? I have to do this. I have to do that, all that. Yeah. Okay, sorry, it's too sensitive. If you look there at the top row is Japan and 2000 and projected out to, what do I have? I think I have 2050. Yeah, 2000 to 2050. And, oh, I'm sure I do. It's so small on my thing I can't read it. But Japan's population today is 17% over 65. Compares to our 13. Japan by 2050 will be at least 34%. At least. Same is true for Italy. And if you actually look at the circumstances for the Eastern European countries where women are averaging barely over 1 child per woman, they're going to go higher. Southern Europe, Eastern Europe, fertility is phenomenally low. Japan as well. These projections by the U.S. Census Bureau are, frankly, what I think, a little overly optimistic. They assume that there will be a bit of rebound in fertility in those countries. Italy has been what we call way below replacement since 1970. This is Italy. This is not Bulgaria. This is Italy, family-oriented Italy. Just hard to find any children there. And there's lots of debate about why it's so low in some of these countries. Certainly economic conditions in Eastern Europe are playing a very big role. High cost of living in Western Europe is probably playing a very, very big role. And maybe in Italy, it's because when they interview Italians about it, the Italian women have this ideal of how children should be raised, which is incompatible with working mothers. So maybe their expectations for what parenthood involves is unduly high or something like that. I don't really know. All I know is I've been watching Italy for over 30 years now, and I've been shaking my head and saying, it can't go on like this. There won't be any more Italians.
Could it have anything to do with the fact that maybe women are having a little more power over their own bodies and making those decisions without it being forced on them?
Yes, I'm sure it absolutely does. And not only that, having better technology to achieve desired goals. I mean, modern day birth control is a lot more effective than many of the forms of birth control practiced in the, prior to 1960, when the pill and the IUD came on the market. So, absolutely. Changing the role of women, it's all about the changing role of women, and what isn't about the changing role of women is about the changing role of children. Little digression here. But think about the difference. In the early part of the 20th century, Europe, like the United States, was still primarily an agriculturally based economy. Most families still lived on farms. And on a farm, a child is an asset. A child's another set of hands. Milk the cows, collect the eggs. My mother started driving a tractor at 9. So children are producers in an agricultural society. But of course, the story of the 20th century was a story of transition from agricultural societies to a post-industrial society where children become a consumer and a dependent for an extended period of time.
So what does China look like?
China's fertility is below replacement.
It is.
Way below. China had a one-child policy.
Oh, that's right, they had the one-child policy.
But China's not averaging one child, but in the urban areas like Beijing, people are having just one child. Peer pressure, the way the Chinese have brought down their fertility certainly violates most anyone's conception of human rights, but they brought it down rapidly. Now, in the rural areas, they've been relaxing the policy in China because actually someone showed them the projections of the age structure. And they said if you go to one child, what is your age structure going to look like? It's going to look like Tempe City Hall. It's an upside down pyramid. It's unsustainable. Let me get the one back and then I'll come to you.
Several years ago, we were bombarded with the dire future of overpopulating the earth. And there was a big campaign to reduce the number of children being born throughout the world. There must be some happy medium somewhere. We don't want to populate ourselves off the earth. On the other hand, we want to maintain a society that's going to be self-sustaining.
I think it's all about sustainability, and I think that's the issue we really have to ask ourselves. I agree. I mean, Paul Ehrlich's population bomb took me out of, I was a zoology graduate student, and I moved from that into sociology and demography because I was charged up by the mission. And then I realized Paul Ehrlich was a butterfly researcher, and not that there's anything wrong with that, but those populations turn over a little quicker than human populations. And I realized that human populations have this other thing called culture going for them, which makes the whole situation a lot different than it does in an insect population. However, I think that one could argue that there are already societies out there that truly are overpopulated and unsustainable, like the United States. Our standard of living is an unsustainable standard of living. Our standard of living depends on reaching out throughout the rest of the world and sucking in the resources, material and human, of the rest of the world to support our lifestyle.
That's exactly what we do. Yes. Exactly.
And of course, since 9/11, we realized how precarious that standard of living can be when it's so dependent upon the flow of resources, material and human, from the rest of the world. So I think that there are unsustainable populations out there, and certainly overpopulation is a critical issue for many countries today. On the other hand, it's hard to know what the maximum population is that could be supported from the earth because it's based on what the level of technology is, what the nature of technology is. The carrying capacity is always changing in response to technological innovations. And I never like to discount that too. But I think it is still a worry. And we still have plenty of countries. Italy could have a lot more population. Almost every Albanian would like to come on board. And these days, Italy is getting a flood of illegal immigrants from Iraq, Iran.
So what's the ideal sustainable ratio?
That's hard. That's a hard question to answer. I mean, we're
already told you that.
We're already over 6 billion. We're going to hit, short of unforeseen radical changes, at least 9 billion in your lifetime, my lifetime. Most of that additional population will be in Africa, parts of Asia, not China, but parts of Asia and parts of Latin America.
In regard to a sustainable population, what about climatic changes?
You're out of my field now, other than what I read is it's a worry. It's a worry. I mean, we don't support a New York City without greatly changing the nature of the local climate. Yeah, oh, I'm sorry, I didn't get back to you.
What are the birth rates in Mexico? Those have gone way down.
They've gone way down.
Way down. What's the structure?
Oh, I hate to say the wrong number, but it could be, I believe, about 2.4-ish. That's a little more than they need for replacement. But Mexico has gone down considerably since the mid-'70s.
Right.
Prior to the mid-'70s, the Mexican government took a hands-off policy towards family planning programs and wouldn't support them because of the pressure of the Catholic Church, where, priests and the local indigent rural parishes were all about bringing down the population, but the official government didn't get involved until after the mid-'70s. And once the government got involved, and they have aggressive family planning programs in Mexico, fertility has been falling. An awful lot of the family planning programs in Mexico are funded by the Rockefeller Foundation, Ford Foundation, which have put a lot of money into making contraceptives available in Mexico. So Mexico's fertility is falling, still above replacement. They're still going to grow. They are a very, very young population, and that gives it a momentum for growth. So they'll still be growing. So the pressure to come in the United States under the economic conditions that their population is growing in will continue for the foreseeable future. I can't see any let up from that. But what I do see happening is Mexico increasingly being a destination for immigrants from poorer Latin American countries. And so while we cope with Mexican immigration, Mexico is coping with Southern immigration to their own borders. Okay, so what really matters here, because I got to get to the healthcare, is the raw number of older people, those people out there that need services. And this next chart here shows you Medicare beneficiaries' self-reported diseases. And I don't think there's any surprises here. The most common, the first bars there, this is for male and female for those who might not be able to read the labels at the back. More than half of the population reports problems with hypertension, and then the next really common problem is the third set of bars, which is arthritis. And 61% of females, 49% of men report having problems with arthritis. Other things that are out there would be, that might be of particular interest, if you look over there at Alzheimer's disease, that's the last set of bars. They're very small right now, but as we all know, people with Alzheimer's are people that need 24/7 long-term care, very expensive long-term care. Right now, 6% of males and, 6% of females, excuse me, this one is full. 6% of females and 3% of males have Alzheimer's disease. Diabetes, which is the second set of bars, is rising. And because of the secondary effects of diabetes, this is a bad curve itself. Because we're talking chronic, serious healthcare needs. So that looks at the overall health profile of the population to a degree, and here are the raw numbers of people that will need care in the 21st century. In 2000, we had 35 million people, 65 and over. If we look ahead to the end of the century, 2100, the number's going to rise to 131 million people. I mean, you saw this in the age structures, but these are the raw numbers, 131 million people. The reality of the situation is most people 65 to 74 may have some health problems, typically some hypertension, some arthritis, maybe a little this, a little that, a little bursitis, but are mostly doing okay. When we go to the middle-aged old, 75 to 84, healthcare problems get more serious and more common, and when we go to the old, 85 and over, the needs get intense. And this chart shows you Medicare enrollees, elderly Medicare enrollees, by what we call functional status. I'm going to just take a little minute to talk about this concept. I don't know if you've ever heard of this, but it's the government came up with this classification scheme some years ago, and I kind of like it because, yes, you can have problems, but the question is, what is the impact of problems on your everyday life, right? And so we have two ways of measuring that. One of them is something that we call the instrumental activities of daily living, the IADLs. Now, these things are, can you shop, can you manage your money, can you get your groceries, you know, that kind of thing. Can you do your yard work? Can you do your house cleaning? If you have a deficit with one of the IADLs, it is not incompatible with staying independent in the community. Because You might have a family member that can pick up the slack. You might have a volunteer. There are volunteer groups that go out there and help that can pick up the slack. And if you have the resources, you can hire those services. Meals on Wheels can bring the food if you can't prepare your meals.
There you go.
You don't even need someone close by to manage finances. So, IADL problems are not that serious. I mean, they're serious to the people involved, but they can be managed. They're not incompatible with independent living. Now, the other set of, the other category up there is ADLs, the activities of daily living. And these include, can you use the bathroom? Can you shower? Can you get dressed? Can you eat? Can you get in and out of bed? If you have deficiencies with one of these activities of daily living, these are personal, intimate activities of daily living, you need somebody close by 24/7 to remain independent. This is sort of the critical point. Because using the toilet is something that's a 24/7 issue. So it's not as easy. It's the deficiencies in ADLs among people who don't have a caretaker that leads to institutionalization. And so, looking overall at the population, more than 1/3, more than 1/3 of the Medicare population needs assistance with at least one activity of daily living. Now that doesn't mean they're in a nursing home or an assisted care facility, but it does mean that they need a little help with one of those really personal care items. This is a measure that I think is the critical measure to keep your eye on, and it of course interfaces with age. And what I have up there now is the proportion of the population having difficulty with one or more of the activities of daily living by age. And I don't have, because I couldn't find it yesterday, I don't have the 65 to 69 category. I'm really sorry. I looked everywhere. And I couldn't find recent data on that. But so what I have is the first set of bars are 70 to 74. So already we see a substantial portion. If I had 65 to 69, again, take it on faith, but I'd be skeptical about that. It's a lot lower, all right? But once you get over 70, the 70 to 74, you have 17, almost 18% of men and about a quarter of women who need help with one of those activities. Now, it might be just that they need someone to do the back zipper when they're putting on a dress. You know, it could be that mild. Or it could be quite major, as you need help transferring in and out of bed. Could be both. You can see it climbs 75 to 79, climbs again 80 to 84, and let's move over to the 85 and up population, because there's where we see the numbers that give us pause. 42% of men and 55% of women 85 and over need help with one of those activities.
Why is there such an age gap?
Why is that disparate?
I'm not, a gender gap, rather.
Yeah.
Um,
You think it'd be, women?
Why males need less
Women are
help?
wusses.
Say what?
I want to hear what your hypotheses are.
That's what it is.
That's it. I heard it.
They died.
They wore their
They
coats.
died.
I don't like that answer at all. I don't like that answer.
They are. It is a comparison to people alive, but men with the problems are more likely to have already died. This is the residual. These are who are left. It's Darwinian survival. And male mortality, it's a case where men die. All right, that would be the public health answer. Now let me give you the sociological answer. Men will deny. Men are far less likely to seek medical care than women. They're in denial about it. And so I would be more skeptical about the responses from men on their functional status than I am from women. And there's another really important factor in this picture, and that's the living arrangements. which are very different by gender. And I was just looking to see if I put the slide in, but I don't think I did. I don't see it here. I was thinking of putting it in. The reality of the situation is, if you look at the population of men, maybe at least, who are 85 and over, I believe it's about 60% of them live with a spouse. I might have put that in someplace. I don't know where I put it. The exact number. I believe it's about 60%. I didn't put the chart in because I have so many charts. But it's about 60% of men 85 and over live with a spouse. Several reasons. One, for starters, it's normative in the United States for the bride to be a few years younger than the groom. Two, mortality reaps its grim effect. And there's a huge difference in the mortality rates of men and women. And three, following widowhood or divorce, who's more likely to get remarried? By far, men. So men,
Wait, who are they marrying?
younger women.
Younger women.
Take care of it.
They don't need,
That's what I did.
They got the spouse at home.
Oh, so they're marrying women that weren't divorced or widowed. I'm trying to figure out how that.
Or even never married.
Never married, yeah. Okay.
I mean, come on, how uncommon is the 55-year-old marrying the 28-year-old?
Right.
And besides Demi Moore, it doesn't work that much in reverse.
We're getting, anyway.
But, policy recommendations, women should marry younger men. It's demographically correct.
Yeah, but they don't have any damn money. Their men are paupers.
I'm gonna go find me a 40-year-old man.
Haven't met my mother-in-law. She's 91.
Oh, yeah, that's true. If you could
Living
just
on her
get
own,
them
and much to my horse
educated.
still driving her car.
If you get their nose out of your.
I'm going to grab those keys soon. But no, today's older population had a lot of exercise in their younger years, didn't have the availability of the entire fast food industry, to clog their arteries to the same extent. Today's older population lived through sugar rationing in World War II, structurally reducing the risks of diabetes. I can think of lots of reasons why today's older population is in pretty good shape, all things considered.
Define the difference between the mortality rates of males and females. Why do women live 8 years longer than men or thereabouts?
Because men are ready.
Well, my students say it's because the women are working the men to death. They actually say that. Every semester when I talk about this, I throw it out because I know I can get that response from them, and then I can go horrified. And then I can tell them that, oh, you want to talk stressful job? Let me put your daycare worker against a CEO any day of the week. The daycare worker who may or may not have benefits, and the CEO's got Cadillac health insurance, and a whole network of people to help out with the stress of the job. Okay, the answer would be multifaceted. One, from the moment of conception, there is a higher mortality for males than females. More male fetuses are spontaneously aborted than female fetuses. It carries over right after birth. At every single age in the United States, and in any country with low maternal mortality. You need low maternal mortality. But in any country with low maternal mortality at every single age, women's mortality is lower than men's mortality.
Men of the hunters. Men of the sky.
Why is that?
Men of the.
Now, we do see something interesting happening after 50 for women. Suddenly, heart disease goes up. Now, what happens around 50 for women? Which points the finger towards something protective about estrogen. And after menopause, women lose that protection very rapidly, and in fact, heart disease is the #1 killer for women, which women need to be aware of. But it seems like there's something protective about estrogen. And, why don't men, my students, I love it in my house, some men say, well, why don't they give men estrogen pills? I said, well, you probably wouldn't like the effects on your secondary sexual characteristics. All right, that's so. There does seem to be something physiological. There are a whole bunch of genetic diseases such as hemophilia that are carried on the X chromosome that disproportionately, because they're carried on the X chromosome, affect men. There's that. There's the physiological, and then there's the cultural. Now, you all live in Arizona. You know how periodically you read about somebody jumping off one of those cliffs in the river and diving down into the below, you know?
It's always a man?
It's always a guy.
That's what
They've
I'm
only, in all the time I've been in Arizona, only one female has ever been killed in one of those incidents. You know how she was killed?
Jumping
No,
with
she
a
was
guy?
hit by a guy who jumped off the cliff. Took her out. This culture is unhealthy for men.
What about military?
Military, all right, that's institutional. I'll go there too. That's another level. I was at culture. Let me finish culture to just say that this culture, I like to make that point, is very unhealthy for our young men. It encourages our young men to take all kinds of risks. And it glorifies risk-taking. And if you don't believe me, just turn on MTV. It's all about risk-taking. To be a man in the United States means to, you know, leave your brain someplace else and take on a lot of risk. Now, institutional, sure. Women are prevented from combat roles. We could even talk about the long history of discrimination that has kept women out of many occupations that are higher paying but also risky, like construction work, firefighting. Police work is not as risky as you think, actually, but firefighting is. So it's institutional, it's cultural norms and values and ideologies, it's physiological, and it's genetic. So it's multifaceted. It's a great question. I always love to get it. At the back?
Yeah, what's the corresponding statistic? You said 60% of the men in the very older group live with a spouse. What's the corresponding rate for women?
I got it here someplace. I think. Oh, here it is. 30%.
Wow.
I was looking for it before and I didn't see it. 30% of women over 85 live with a spouse versus almost 60% of men over 85. It's a huge difference. Oh. Well, I think probably it's time anyway. But yes, it's a huge difference. So those are structural factors that have a big impact on your quality of life in old age.
As an example of why demographers are always wrong, who would have predicted that it may be that there'll be far more gay couples living together, women, men, which will obviously skew some of those statistics.
You know what that will do? It will increase life expectancy. It will. Because the worst life expectancy is found from single men. Now, you could talk about self-selection. Who's a single man? Is he single because of bad, risky behaviors? Is that what led to the divorce or the never married? You know, you could talk about that. But without, I mean, the figures, I don't have them with me today, but the figures are really startling. Single men's life expectancy is far worse than married men's. And married men's life expectancy is not as good as single women's. And single women's life expectancy is not as good as married women. What it really talks to is that one's life expectancy is not just a product of physiology and genetics, it's also a product of your social support network. So I would have every reason, I've even been thinking about that with all the goings on in San Francisco and now New Mexico, that, how do I want to put this? That as society changes and becomes more accepting of gay couples living together, it should improve their life expectancy. Yes. Sometimes the good news has a bad lining to it. You know, this is the black lining in the cloud. Okay.
Because we start on it and we'll cut down that fertility rate, right?
You think so? I think so.
That'll make the bad curve worse and worse.
Well,
Yeah.
does making it legal make the number of people who live together different?
Well, once society...
Presumably it does. Because if you've got someone living with you and you start to have some physical symptom, come on, those of you who live with someone, you know what happens. They say, go to the doctor. And if you don't, they get on your case and they start pressuring you. Go to the doctor. Under those circumstances, you're more likely to go to the doctor. And you do.
That's what Sharon did.
On the other hand, apparently shortly after menopause, men die.
Shortly after menopause.
Well, that's what your chart seems to show. It's a long story.
Oh. I know they say that there's a male pause. They're starting to do some research in that. When that would be, who knows. There's certainly an increase in divorce rate after 20, 30 years of marriage. Do you know about that? The divorce rate is soaring for people with long-term marriages, 20, 30-year marriages.
Japan.
Yeah, it's an interesting statistic that people are watching. Okay. Up here, I think what many of us, I guess I'm putting my own anxieties here, what many of us worry about a lot when it comes to aging is the notion of potential memory impairments.
Yes.
And the inability to function because you can't. It's my nightmare. I don't know about you. I think I could take all those physical things pretty well in stride, but I think I'd have a lot of trouble. As my 91-year-old mother-in-law says, I thank God every day, at least I've still got it up here. And I feel I would probably think the same. But the reality of the situation is just as physical chronic diseases increase with age, memory impairment increases with age. In the 65 to 69-year-old category, the first set of bars here, 5% of men, 4% of women have some kind of memory impairment. It's pretty low. It increases, as you can clearly see, in the 70s and then the early 80s, and by the time you get to the 85 and over category, you're looking at 37% of men and 35% of women with moderate, we're not talking just forgetting what you came into the room for, but moderate to severe memory impairment. And then what we all, I think I can safely say, Brad, would be the issue of Alzheimer's. And if you haven't had somebody in your family go through it, it's a pretty horrific thing. We're looking ahead to projections about how many people in the United States will have Alzheimer's. I found this from the Alzheimer's Disease Association. This chart, I just plucked it out of something of theirs. Back in '95, we had 377,000 people in the United States who were diagnosed with Alzheimer's. Looking ahead to 2050, I mean, it's driven by demographics here. We're expecting nearly 1 million people in the United States with Alzheimer's. And even though sometimes families try to maintain people at home with Alzheimer's, it just usually can't work out without a huge support network of help. So, I don't have anything against people over 85. I hope to be over 85 myself. But obviously the worry is this bad curve. And when it comes to healthcare in the 21st century. Back in 2000, a few years ago, we had about 4 million Americans over 85. Looking ahead to 2100, that's going to go from 4 million to 37 million. 37 million people over. It's like a multiplier effect when it comes to healthcare needs. That's what demography is really all about here. And if we look at the likelihood of being in an institutional environment, a nursing home, it increases dramatically for the 85 and over category. Almost 20%, almost 1 in 5 people over 85 are in a nursing home. And that is a nursing home, that's not assisted care. Yes?
Have these figures taken into consideration the advances in medical science that appear to be also
Yes.
progressing quite
If anything, I think they're overly optimistic about those advances in medical science. But yes. And if you look, because of the lifetime of demographics, if you look at nursing home residents, you'll find that half, this is another way of looking at it, look at who's in a nursing home, half of them are going to be over 85. 3/4 of them are going to be what gender? Female. Because they kept their husbands out of it. The husband dies and then they're in it. And 96, Americans do not pop mom and dad into a nursing home to get them out of the way. The people in nursing homes need to have skilled nursing care 24/7. 96% of them need help bathing or showering. 45% of them need help with eating and so on. The reality is, as I'm sure some of you are aware, that nursing home care of a long-term care in a nursing home is not covered by Medicare. It is covered, once you're indigent, by Medicaid. And so Medicaid really, which was originally set up to provide health care access for the widows and orphans kind of legislation. It was for single moms and their dependent children back in the 60s when they put it into place. But it has become the primary payer of nursing home care because costs these days, $4,000 to $5,000 a month, doesn't take you too long to run through a middle class, even a middle class family's assets, and you become Medicaid eligible. So, oh, I have another failure of a chart. Oh. Well, shoot. What this chart is going to show you is an important point because one of the big sort of structural changes we've had in the United States is we've had a big growth of something called the assisted care living industry. And this industry in many ways has creamed the crop of nursing home because it takes those, instead of who wants to go to a nursing home? Nobody. But people who are able-bodied enough so that they can pretty much do the activities of daily living, maybe with just a little help with some of them, they can move into an assisted care facility. And a much more pleasant environment by and large than a nursing home. And it has grown extremely rapidly just since the mid-90s. And what I had here was a chart that showed the enormous growth of assisted care facilities relative to nursing homes. Nursing homes are in trouble these days because nursing homes these days only have severely needy residents, which means that the cost, that has helped increase the cost of nursing home care. Now, why did that chart work and the last one didn't? I don't know. If you look at per capita expenses for long-term care facilities, the first bar is the community. It doesn't cost too much to keep someone in long-term care in the community. That's why we would try to keep people as independent as long as possible, because the burden for society is much, much less. And guess what? In general, people prefer that. So it's a win-win situation to keep people in the community. The second bar up there is in the community with skilled nursing stays, and that certainly is more costly. The third bar is nursing homes. That is, as you can see, very costly. And the fourth bar there is assisted care living, which is not quite as costly in total as nursing homes. But you see how these bars are subdivided? And those subdivisions deal with where the source of the money's coming from, whether it's out of pocket or whether it's from one of the government programs, Medicaid or Medicare. And the bar, boy, I apologize, this did not come out very well. The bar that's blue, which looks green up there, $15,332 come out of pocket per year on average for assisted care living. So it's a big part of, it's a big difference between whether the individual has to pay for it and whether one of the government programs will pick it up. One of the things this certainly means is that most people in assisted care are middle and upper class people, upper middle and upper class people who can afford the fairly substantial cost of assisted care living. All right, so the bad curve. I got a bunch of bad curves here. Here's Medicare spending from 1967. The program was instituted in 65. So back in 1967, the U.S. was spending about $3 billion a year on Medicare. Trivial. By 2001, it had moved up to $241 billion. Actually, I checked, and the most recent figure is for 2003, which I added up there a little bit late last night, $278 billion. Yeah. I mean, this is an exponential growth curve. And I'm sort of going way long. So I was going to tell you a whole lot about Medicare financing, so guess what? I'm going to skip that, all right? I'll move right on to the projected. This comes out of the Congressional Budget Office. I found something as a sociologist very interesting about this chart. What I found interesting is that looking at the projection, they hedge their bets. There's 3 different projections, right? They don't put a dollar amount on their projection. They put instead the projection as a percent of gross domestic product, GDP. All right? No dollar amount up there because guess what? It would be too frightening. So not only that, they actually have 3 projections, the top one of which assumes that Medicare spending is going to be in excess of the growth of GDP by 2.5%. I found that rather interesting since Medicare spending has exceeded GDP growth by more than 3% since 1970. So even their top projection is, to my uneducated, non-economist eyes, wildly optimistic. The middle range projection assumes that Medicare spending will exceed GDP growth by 1%. I think that probably is near laughable. And the lowest is that there'd be no excess. It would rise just with the rise in GDP, which is truly a joke. Unless suddenly there are major changes in the structure of healthcare delivery in the United States. So the other thing I found rather interesting about this chart is if you look at the high projection, the one that I think is probably not too accurate, probably even underestimating, do you notice that the chart goes off the top? They didn't even want to put the percent up there. You know, I was trying to figure out what it would be. I think it would be close to 20 when I tried to figure the scale and the direction it was heading. It's a worry. It's a worry. I mean, we're currently spending about 2 and a little percent of GDP on Medicare. That is just Medicare. That's not all healthcare. It's just Medicare. But we're looking ahead to where Medicare itself could be at least a fifth of the federal budget, and maybe 20% of the federal budget. I don't know. I think it comes back to that concept of sustainability. I think it's unsustainable. The burden on our children is unsustainable. So, the Congressional Budget Office also thinks it's unsustainable. And they have listed, I'm going to give you the official line here, some options for how to slow it. Oh, I neglected slowing the growth of Medicare. This is near the end, so I was getting sloppy. Okay. The first thing that they suggest is that you could reduce the number of people receiving Medicare benefits.
What are you going to do, shoot them?
How would they do that?
Raise the age.
The same way that they're trying to reduce the number of people receiving Social Security benefits. They can increase the ceiling. And so there was a big discussion in their most recent report about how you could increase the age to 70. But the Congressional Budget Office itself said that this would help a little bit immediately, but it wouldn't, and I'm going to quote, solve the long-term fiscal challenge ahead. Second thing that they said is that you could reduce costs paid by the government. And of course, how would they do that? Increase the co-pays, the deductibles, limit the... Oh, they actually talked about limiting the amount of supplemental insurance that you could purchase to pay for your health care expenses that are not paid for under Medicare. Why would they want to do that?
More concerned about the cost of your care.
They want to make you price sensitive.
Yeah.
They want to make you feel the pain and think twice about getting the care. That's why. And then the last of their options are to reduce the total cost per beneficiary. And what's that about? They've been doing a bit of this, trying to reduce payments to the providers of health care. And, you know, this is through the DRGs and the recalibration of physician payments. I'm trying to think of the acronym for that program, but that one I always get mixed up. But, you know, basically they've increased payments to primary care practitioners, relatively speaking, and decreased payments to many of the specialists, relatively speaking. So those are the standard solutions, and you know what the Congressional Budget Office people say? Won't work. The bad curves are coming. Other strategies. They even have a section in their report where they say, we've got to think more creatively. And one of the ways they think more creatively is to introduce greater competition into the Medicare market. That's a synonymous with privatization and commercialization. I'm not too fond of that in healthcare. I think that would be somewhat like the way Arizona put into effect its Medicaid program, where it has different provider groups bid for contracts to cover X number of people and so on. You know, that's trying to put competition to push down the provider costs. So they talk about that. They talk about converting Medicare into a defined contribution plan. Hey, you lived through the conversion of defined benefit to 401ks.
Yes.
So you know what that's about. Making us responsible for an ever larger portion of the premium that would exceed whatever the government might decide it would kick in. Impact, according to the Congressional Budget Office, unknown. Lastly, on their creative strategies, employ disease management and case management. And this was actually creative. The American healthcare system, if we can call it that, is a system that is all about treating people at the end. There's sort of a joke in medical sociology, which talks about some poor doctor who's downstream and he's busy pulling all these sick people out of the water. And he's so busy pulling all these sick people out of the water, he doesn't have time to find out who's pushing him in. We have a downstream healthcare system. We put enormous amounts of money into treating the crises once they have developed and flourished. We don't put much money into, we do, I won't say we don't put any, but we don't put relatively anywhere as near as much money into prevention. And so this was actually creative. But as the Congressional Budget Office says, impact unknown. Now that's all they talked about. I'm going to offer you my creative alternative strategy. My creative alternative strategy is, let's rethink the entire so-called system. No other country spends as much per capita on healthcare as we do. Yet our life expectancy pales by comparison to most European countries. Costa Rica. Been to Costa Rica?
Yeah.
Nice place to visit, but kind of a poor country. Costa Rica's life expectancy is right up there with ours. An increasing number of middle-range developing countries' life expectancy. Even China's getting close to us. And believe me, they're not spending the same per capita dollars on health care. Why does the United States spend so much on health care? Much of our healthcare system is in the private sector. It is entrepreneurial, it's for-profit. It is enormously politically powerful, as we just saw in the debates about the prescription drug coverage coming in under Medicare. We pay a huge amount for health care that really is just profit. It's a jobs program for the upper middle class and upper class. And it's profit for the shareholders in the various hospital corporations and pharmaceutical companies, the imaging, freestanding imaging centers and so on. So it seems to me that we need to rethink the whole system. We need to rethink how much we want to pay to profit small elite population. You know, what expense do we want to do this when we're facing the bad curve? We could afford to do that in the 60s and 70s, but now we're facing the bad curve. It's imminent. The other thing about the U.S. healthcare system, and we can compare it, say, to our northern neighbors, Canada, is that we have a system that includes a tremendous administrative overhead in terms of all the different insurance companies, and there's a whole industry out there that's all about processing the paperwork for claims. It is a burden on individual physician offices. They have to hire people to deal with all of the administrative costs. So I guess I might think we need to start from scratch, rethink what the goal is here. I have no hope this is going to happen, but let me just stand up here and say that we ought to think about alternatives such as a universal health care system that provides basic coverage for everybody. We don't need to provide everything for everybody. We clearly know that healthcare demands are a bottomless pit. I spent a decade researching cosmetic surgery, and the amount people are willing to pay out of pocket for that is fairly astounding. So demands are a bottomless pit, but if we covered basic, cost-effective health care, it would certainly go a long way towards trying to cope with the bad curve. That's the end. Yes.
I'm just wondering how many pharmaceutical and medical research facilities does Costa Rica have?
Costa Rica's full of them. Do you know that?
I don't know that. That's
Oh
why I
yeah,
asked the
Costa Rica's
question.
actually full of them.
If you appreciate the Humanist Society of Greater Phoenix and would like to see more, then subscribe to our channel and check us out on Patreon. Links are in the description.